Hi, Don here. Welcome to the $1 Million Minute. We're going to go over kind of the things that help get the practice to the $1 million mark and beyond. Once again, thank you for everyone that has been sharing this with friends. I got an email from one of the listeners, and he said he's sending it to his friends in Chicago. So if you have other friends that you think that you went to residency with that would benefit from this, let me know. Send it out to them. Just send them the link. I think I try to put a lot of time into this and try to give a lot of value. Okay, let's go into my day. This is a recording for a Tuesday, and there were 22 patients. There was one open slot. My 8 a.m. slot was open. So let's kind of go down the list here. So the first one was a 71-year-old that came in, new patient, was for an IND. So that was a level 3 visit, new patient with an IND. Ingrown toenail, I'm not going to see them back. So once again, the goal is to reduce low-value follow-ups at where I'm at right now in practice, and then have more most valuable patients, so patients that are more profitable. If you are just starting out, in every patient you have to see back. That's what I would say. So I used to see all ingrown toenails back when I had an open schedule and I needed those lower level visits. But now it's kind of a full schedule, and I'm only seeing back the ones I need to. Next patient was a 82-year-old. This gentleman, he had flexible hammer toes on the left foot, 2 to 5, and they were hammered down. They were really causing imbalance issues when he was trying to walk. So we did flexor tenotomies of 2, 3, 4, and 5. I did them with an 18-gauge needle. One little mistake, I think my staff was asking me about anesthetic. And so I like to share the good, the bad, and the ugly, okay? So she was asking me about anesthetic, and I'm like, yeah, I need, probably only 2 anesthetics. And she asked if I needed lidocaine, and I said, yes, I need lidocaine. She understood lidocaine as lido with epi, because occasionally I use lido with epi. So the first 2 anesthetics, and they usually draw it with red on our little injection needles. Usually they write epi with red, so we know that. But the first 2 toes, 2 and 3, had epi in them, and the 4 and 5th toes, they didn't have epi in them, because I started drawing it up. I'm like, why is this taking so long? We usually have these pre-drawn up needles. So in our office, we pre-draw up what we need for the day for the anesthetics and also for the cortisones. I don't think I mentioned that in the past, but there's pre-drawn up cortisone and anesthetics, the non-epinephrine ones. If I'm doing a biopsy where I want that control of the bleeding, then I'll use epi, lido with epi. But usually in the toes, I don't use epi. So I was a little concerned, and so I'm going to call this patient today, make sure everything's okay. Older patient. He had good pulses. I think he's going to be fine. But there was less bleeding doing this. So I did, and I'm going to see him back in 2 weeks for this. We're going to get x-rays. So usually when I do the flexor tenotomies, I just put the 18-gauge needle, I think everyone knows, have him pull down his toes, and as he's pulling, then I cut, and then the pulling goes away. I put a little steri strip on there, and then I wrap it with Coban, and then he changes the Coban once a day, the 1-inch Coban. X-rays next visit. Next patient was a 69-year-old. This was my MVP, most valuable patient of the day. She's coming back. This was one that she wasn't ready for the treatments that I was recommending for Shockwave and things like that. She wanted to try, icing, anti-inflammatory, stretching, night splint. She did that for a couple months, did not get better, and now she's coming back, and she's going to be going to Egypt in a couple months. So I kind of went over the options. I did an ultrasound, and I showed her that her painful side is thicker than the other side. And then I kind of went over and said, well, if it's thicker, you have the options of cortisone, which can make it feel better for a little bit, but it doesn't usually work long term. Or you can do what I recommend, which is doing Shockwave with orthotics. And so the Shockwave, I did session 1 that day, scheduling the other 6, and we also scanned her for orthotics that day. So that's the kind of the package that I do for patients, orthotics and Shockwave. And this came from my recent coaching session with Paul, where he's saying, Don, you just have to include it as a package. Like, this is how you do things. You do orthotics with the Shockwave to help the mechanics of the foot so it doesn't keep coming back. Okay. Next patient was a Lamisil number 1. This is a new patient. She came in actually looking for laser. I tend to talk more patients out of laser than into it. I do have lunula. I just don't find it works all that well. This is a 28-year-old. She had a very thickened toenail. So I said, you can either do the nail sample and see you back in 3 weeks, or we can just skip that first process and just go right into the medication. So she did that. We ordered LFTs and started her on the medication. So because of the medication management, that was a level 4 visit. I'm going to see her back in 3 months. Next patient was a 52-year-old. This was number 4 of 4 for Shockwave. She came back. She was concerned about finances. She was feeling better than when I originally saw her. She had a lot of pain initially in her plantar fascia. So she did another kind of a booster touch-up session. I recommended another 3. She wasn't able to do that. So what we did is I did another 1, and then I recommended she get some Alleviate tools. If you haven't seen Alleviate, I think it's like Alleviate.com or something like that. It's like a self-grafting technique. So I recommended her to get that. We have these in one of our offices in Westboro. We don't have it in the Worcester office, but I did recommend that for her. She wanted to do something on her own. She didn't want a lot more Shockwave. She didn't want cortisone. She didn't want orthotics. So in that case, I'm not going to see her back. I'll see her back as needed. So what I'm finding, and this is kind of an advanced technique for me. In the past when I was starting, I wanted everyone to come back. And now I tend to only want those to come back that are willing to do what I recommend. So if they don't, then either I'm not seeing them back or I'm going to see them back in a big time frame, like 2 months or 3 months, because they're just, they have to feel the need to take my recommendations. Next patient was a 49. This was a no follow-up, but a partial nail avulsion. So the distinguishing factor, I think, is infection and redness and swelling. And so there was none of that. It was just like an ingrown toenail with a lot of callus in the edge. So I call that a partial nail avulsion. So I use a nail avulsion code for that. Next patient, this was a referral, 25-year-old girl. She's a ER nurse. Came in about an hour, almost, I think 45 minutes. Referred from another doctor for Swift because all they had in this community clinic was like salicylic acid, and she had a mosaic wart. So we'd set up Swift 1 of 4. So the way I do that is when they get the consent, on the other side of the consent, there's a place for 4 Swift appointments. We do number 1, and we set up the other ones monthly. So 2, 3, and 4, and then I do a 3-month follow-up after that. I did offer her cantharidin in conjunction, and she had previously tried like 5-fluorouracil. She's tried the freezing stuff. I did offer cantharidin, but because she had to work, she did not take me up on that, which would make sense because it blisters a lot. But I recommended next time she would come in after her. She does 312s for her work, and so after that last session, I would recommend her coming in. And I did contact that doc and thank him. Next patient was a 41-year-old. She was here for EPAT number 3. So usually at EPAT number 3, if I'm doing 6, the third one is where I scan people for orthotics. My thought is initially when they're starting, orthotics are uncomfortable. Initially when they're starting for heel pain, for example, everything is uncomfortable. So by session 3, they start to feel a little bit better. By 6, I know they're going to feel a lot better. So that's why when I do it at 3, they'll come in at session 6, which is they come in about 3 weeks later. So that's why I scanned her. So there was 2 orthotics so far. Next patient was a 71-year-old that was here for like a matrix follow-up. She was totally fine. I'm not sure why I had her come back, but she did come back. I normally wouldn't have done that. Next patient was a 67-year-old female that has a really big bunion, and she has a second hammer toe that's overlapping the bunion. And she came in kind of wanting to know if I could just put that second toe back in place. But I had to have that whole conversation saying there's not enough room, the bunion's in the way. She could try a Boudin splint, which she got, but she is not wanting to fix the bunion and her tailor's bunion and the hammer toe. She just wants that hammer toe down. But I said that's not really feasible because it'll probably come right back up. Next patient was an in-office surgery. This was an exostectomy on the medial aspect of the 5th digit. So that's where I numbed the toe without epinephrine, and I did a little incision distal to the soft corn, distal medial, and then I did a elevator, got to the bone, did a bell rasp, rasped it down, flushed it, and I put in a couple of sutures. She's going to keep it dry for 2 weeks. I'll see her back, and we'll get x-rays at that time. Okay. So again, I did x-rays before to show her the condition today, and then I'm going to get x-rays in 2 weeks as well. Okay, that was the morning. Afternoon, there was a patient that had a callus on the 5th med head, also a heel fissure, so we talked about kind of how we treat heel fissures. And hers was not opened as an ulcer, so I recommended the urea cream with the heel socks, and I trimmed the callus. She's not going to come back. Next patient was Achilles tendonitis at the insertion, actually a 42-year-old gentleman, and he had insertional Achilles tendonitis. it's only been about a week. It's starting to feel better already. So I gave him an option. I think it was just an overuse injury. So for him, I put him on meloxicam, and I put him in a tall cam boot to rest the area. I did give him an option of Shockwave, but he wasn't interested. And I think it's too early. I think this might calm down just with resting it. But since he's walking so much and so busy, he wasn't able to just slow down himself. So that's why I put him in the cam boot. I'm going to see him back in 2 weeks. If this thing drags on, then we'll do the next step. But it hasn't been that many weeks. Next patient was a 72-year-old. She was here for EPAT number 2 of 6 for the heel. Next was a 45-year-old, number 4 out of 6 for Shockwave. Next patient was a 77-year-old. Was here for a diabetic foot exam, new patient. He had neuropathy, so we talked about that. I talked about Qutenza. I talked about gabapentin. And he's not really wanting to do either of those. I actually wanted to check on the Qutenza, so I'm going to check on that. He wasn't up to taking a medication, and he has a kissing corn on the 5th toe that I trimmed down. And I talked to him about an exostectomy maybe in the future. I made a 1-year follow-up, unless that Qutenza is covered, in which case we could do the Qutenza. Next patient was a 64-year-old that had a left hallux IND, no follow-up. Next patient was a 27-year-old that did Swift number 3 out of 4. Her warts are greatly improved. She had a big mosaic wart, feeling much better. I think just 1 more session, she should be fine. Next patient this is kind of a unique guy. So he is a 51-year-old Brazilian guy that's on the radio. Okay, so if you don't know, I was an exchange student to Brazil, speak Portuguese. I see a lot of Brazilian patients. And this gentleman, we did a trade. Okay, I don't know if you guys have done bartering or trading. So the trade was the following. I treated him for free, and he was going to put ads on his radio for me. So he's going to talk about his experience dealing with his nail fungus. He was treated previously by primary care for nail fungus. But I think what happened, they didn't treat it long enough. That's why I do the 3 months of the terbinafine, and then I do a booster dose after that. I think he was on it, and then it got reinfected. So I put him on. I got the LFTs, I got the terbinafine, and he got my little kit. So one thing I just want to talk about, I think our tendency, or my tendency, I don't know about your tendency, but my tendency is when I see someone that's self-pay to not do my normal treatment process. So I treat like self-pay patients different than insurance pay or people that I'm kind of judging them. So I try, so this guy I didn't, just because I have everything written on my piece of paper that I use on my treatment sheet, and I just showed it, this is the way I do it. So we do the UV light, do the shoe sterilizer, the biotin, and so he, even though I didn't charge him for my visit, he paid about $200 for all those other things, the UV light, the shoe sterilizer, and the biotin. He had to pay cash for his LFT at the lab, which is pretty cheap, and cash for the terbinafine, which is cheap as well. And he's going to just send me a picture in about 3 months, and I'll send that renewal over for him. So I guess what I'm trying to say is, if how you treat is how you treat, don't change it based on what you think they will or won't do. So I didn't feel comfortable giving him all that stuff for free, even though I was doing the visit for free, because I had to buy it from the practice. And so I only gave him the visit free. He still had to buy those other things. So just kind of a word about that thing. But I don't really do much of this bartering. I thought it was kind of a neat idea. He called me and said, "Hey, I got some fungus. Would you treat me for free if I give you ads on my radio station?" I'm like, "Sure, let's try it." Next patient was a right first MPJ pain. She is back. She has surgery scheduled in the future, but due to the pain, I think it's in September. But due to the pain, we did a first MPJ injection with cortisone. And then the last patient of the day was a 68-year-old. This was kind of a challenging one, and I think we all have these. So she brought her husband in. She has a difficult situation. She had nail fungus. We talked about the nail fungus. And then when I told them about like the UV light, the shoe sterilizer, the spray, and then everything else, she said that, her husband said, "Well, it's $200 is too much. What can you take away?" And I said, "You have to decide that. I can't decide which one to take away." So they went to check out, and I think they probably took something away out of that. And then she also had bilateral plantar fasciitis she's had for a long time. And then they both were about 6 millimeters in thickness for the plantar fascia. And I feel like she would need Shockwave, but that's expensive. Like bilateral Shockwave, you're looking at about $3,000 because it's $1,500 per foot for the 6 sessions. And her husband, they can't afford that. And this is a struggle for patients. So we talked about care credit, and then we also talked about doing a cortisone injection. And so they kind of opted to do, her husband said, basically you have to do cortisone. And I said, might not last that long, but they're aware. And I think as long as we educate patients and they know what to expect, and potentially it could work, but they didn't want to do anything else. And those are always kind of challenging patients. But I know people struggle financially. Like, not everyone has the means to do this. And I think some of you might think, well, I'm in a really like affluent area here in Massachusetts where everyone can afford this stuff. And that's not really the case. So many doctors say, hey, I just can't recommend self-pay things because my patients won't pay. And I think it has a lot more to do with us than it does with the patients, because the patients, if they see value in it, and if you position it properly, like you can try the other stuff first, like you can try the cortisone, but then if it's not getting better, are you just going to keep doing that, or did you bring up the other treatments? So I find that by bringing up the other treatments, when it fails, and you kind of pave the way, saying, most of the time this doesn't work long term, they know and they're aware, and if they want help, they're going to go to the next step, or they're going to go see another doctor. So I did have another patient. This was one. She had a nail issue. She was coming in for the ingrown toenail, but she also had some Achilles tendonitis, so non-insertional Achilles. And the issue is with her insurance. She had an insurance at a big hospital here called UMass, and if they have their own insurance, it's kind of interesting. So Tier 1 is UMass, doctors, UMass X-rays, everything. So everything she did there was really covered by her insurance. Everything that's outside of there was more expensive. So I was like Tier 2. And so if she did X-rays here, it wouldn't be covered. And if she did procedures here, it wouldn't be covered. And so because of that, she saw a sports medicine doctor, a podiatrist in another town like 30 minutes away, because they were on her insurance. And then that didn't work, didn't do anything. And then she saw a sports medicine doctor who's going to do TenJet on the Achilles. So it's kind of, this is a reality thing, but patients, they can't see us sometimes because they have to see others, and they're looking at other approaches. Even though she wanted to see me, she said it just was more expensive, and I think a lot of patients are kind of price conscious. Anyway, if you guys found this beneficial, please share this with others, and if you want to do an audit, like you want me to help you on your practice, go to podiatrypracticemastery.com/audit and fill out the information, and it's going to probably take you 20 or 30 minutes. It's not easy. Get some time. And then we'll meet together, and I'll chat and give you any things I think I can help you with your practice, and you tell me what you're struggling with, and we'll kind of meet, and hopefully that'll help you. Okay? Hope that was good today. Have a good one.